Welcome everyone to our sixth CTS State of the State, right? And everybody can see my slides right now. For those who it's the first time joining us, welcome. We've had multiple different conversations before. I'm Asha Devereaux. I am a past president of the CTS, and also I'm joined by moderators, Drs. Dennis Amundson and Christian Sandrock, and we served on the ACCP's Mass Critical Care Task Force and had been thinking about pandemic preparedness for the last 15 years. And during early January, when things were really hitting the fan and we were running out of supplies, we thought it'd be a good idea for us to have a mechanism to share what's going on, and so that we could all stay connected when we needed to help each other out. So prior topics included oxygen, anticoagulation, running out of sterile water, tubing, ventilators, and the surge vents. This is being recorded, and we thank Fisher Paykel, SmartVest, and Voxen for supporting this platform. So without further ado, we'll get into our agenda for this evening. As usual, Drs. Amundson and Sandrock will run the state, checking in with the ICUs throughout our state. And then the topic for tonight is bronchoscopy and aerosol generating procedures. And we're honored that Drs. Chanik, Drs. George Chang, and Rich Branson will serve as panelists, and that Dr. Carla Lamb from Boston has joined us this evening to serve as kind of our out-of-state expert, since we don't want to be West Coast biased, so that we can learn from everybody. And this is meant to be interactive, and so open for question and answers. And with that, I'm turning the mic over to Dr. Sandrock and Dr. Amundson. Thank you.
Hey, Christian, you started last week. Can I start this week?
Absolutely, please do.
Oh my! All right. Well, as I hope we'll hear that the same things happening around the state is happening on the border down here in San Diego. Our county is now just over 250,000 cases, and we've got just under 3,000 deaths right now. That's the bad thing. The good thing is our case rates have fallen substantially, now about 45. We're still having lots of community outbreaks, though. We have a ton of the community outbreaks, so we're still above that. Our ICU capacity here in San Diego County is now around 19%. The Scripps system where I work, we peaked at 510 COVID patients at one time. We're down to 237, 78 in the ICU. Of them, 69 are on mechanical ventilators. Unfortunately, where I'm at on the border, our case rate still popping right at 60. So we're a little bit higher than the rest of the county. My hospital is about split now. It's about 50% COVID, and we're running 31 on the wards, and I have 13 with 12 on ventilators in the ICU, which is about half of our ICU right now. So what's happening down here? Christian, what's going on up there?
I think the good news is it's pretty boring since the last week, which is kind of the way it should be. Numbers overall continue to decline. Our test rate positivity is somewhere in around 3 to 5%, which is great. Our total number of patients in-house for us remains in the double digits, which is wonderful. We have two ways of counting them. One is those from an infection prevention standpoint who are still infectious. The second is from people which we will talk about tonight, where isolation's lifted. So our total numbers, and those are probably somewhere in the 90s, which has been pretty steady. We were able to decannulate 3 of our COVID patients from ECMO this past week, but unfortunately on Sunday we put 2 new ones on. So we have a net loss of 1 in the good direction, not from a death. So that's sort of where we've been at. I think our biggest stress, and what's probably taken up most of our command center has been vaccine worries. So, you know, I'm not really sure exactly where we are, but I think we are at a point where we're probably going to run out soon with vaccine. I don't know if the rumors are true, but I heard at Petco they ran out today, and that's always a concern with, you know, canceling you know, future appointments as we try and vaccinate. But other than that, vaccination has demanded most of our time. And anyone else from the North State or down in, you know, Denny's side, feel free to chime in if something's different at your institution. We're still, I think when I last looked from our MOAC, we're around, I think 22% ICU capacity in the Northern Central Valley. So pretty good, way better than it was at the peak in late December.
Hi there. We are actually better than the December and early Jan peak, but in the latter part of last week, we have somehow actually seen a uptick. Not in the positivity rate; those numbers still hold up like I shared last week. But the problem is we're seeing a lot of admissions now, both in the hospital and the ICU, that are coming in not because of COVID, but they're coming in with COVID. So and it seems like they're a lot more sicker on the other pathologies, whatever's bringing them in. So they happen to be COVID positive, but they're coming in with additional something else, and they're a lot sicker. So we are right now, we just crossed this morning 50 ICU patients, which was our peak in summer. So I don't know what's driving this. The Super Bowl is too early to blame, but last 3 days, every day we've had about 9 to 14 ICU admissions, and we just bumped up. Our ICU capacity as a whole is around 120%. So it plateaued off for a week or almost 2 weeks. And then last 3-4 days, we have seen a consistent uptick. So I'm getting a little concerned, but yeah, that's all I'll share.
Yeah. Hey, it's George from LA, Cedars. So things are still winding down here at Cedars. I'm not sure about the other big institutional hospitals here like UCLA and USC, but we're ramping down to our 2 usual ICU teams. But although we have less acuity, we still have about 100 so-called COVID recovered patients who are still on ventilators or dealing with some other complication right now. So that's taking up a lot of our resources as well. But we're not admitting as many patients as we were a month or 2 ago. And hopefully that trend will continue.
I can give quickly UCLA. So our numbers are also consistently going down. The floor more than the ICU, but we peaked at around 200. Last week, I think I said about 100. We have about 70 now. About 30 of those are in the ICU. We still have 1 extra ICU team to support COVID ICU and the sort of non-COVID ICU patients that have come back actually in droves. And about 10 of them are on ECMO, but we are still seeing a downtrend, which is good.
I think prior to starting this, again, as I've said at each meeting, the important part is you get your questions answered, and we have our full panel on board now, and I see Rich here. Hi, Rich. And they're here to answer your questions, but in conversation prior to starting this, there was some questions that came up that they had that I'll throw out too, and maybe George can kind of tether some things together. But some of the things that came to our mind was just what you said from Fresno. We're also seeing the incidental COVID positive patient who comes in medically ill. And I agree with you. They're sicker than people that with the same disease, at least in my estimation. That was one thing. What other people are seeing. I think the timing of tracheostomy is something that's changed and evolved a little bit, and I would throw that out to our panel a little bit to discuss. And I'd love to hear what other people are doing. We've certainly changed our behaviors in terms of earlier tracheostomies that we've seen. And then also what came up is how about who's taking people off those COVID precautions, and does being on a mechanical ventilator make a difference versus not, versus being more ill? What criteria are people using in taking off the COVID precautions? And maybe Dr. Chen, we could start with you if you got any ideas.
You wanted
Anybody,
Dr. Chanik or
yeah.
Dr. Chang?
Yeah, either one. Colleen, you want to throw us?
I thought it was a Chang. I wasn't sure it was a Chanik or a Chang.
Oh, sorry. I thought it was you. I'm sorry. I thought I just been quiet.
In tandem. Yeah, I think, you mentioned tracheostomy. I'll be interested to see what other people did. I mean, obviously, we first started to try to push them as late as absolutely possible, but certainly we've seen a trend towards maybe going up to 14 days. I mean, we haven't done, really, at least I myself have not done too many trachs much before then, and that's usually when they're requested. But I think anywhere between, after 14 days, I would consider, I think is a reasonable time period. What are you doing down there at San Diego, George?
Yeah, I would echo what you your experience, Colleen. I think when we first started in this pandemic, we actually had no clue about the disease actually in terms of how long the virus is shedding, how when it's safe, and all of us were kind of for the lack of a better word, flying by the seat of our pants, right? So we were kind of coming up with these random protocols that are non-evidence based. And over the past year, I'm really glad to see that, societies are putting out guidelines that are evidence based, and publications coming out initially from New York City, and then our European counterparts to kind of shed light on the viral replication cycles and how long it takes for us to roughly fill some type of evidence to say it's a viruses, even though you're detecting viruses, but they're not in they're not infective in a level that's effective. So when we first started, as you mentioned, that we were pushing it back out to as late as possible, 21 to 30 days, and that already in itself created a backlog. And then when the when NYU paper came out, they were really doing the exact opposite, as you recall, because during the pandemic, there were a lot of during the peak, they were having a lot of resource allocation issues, and they were treating the patient much earlier, within the first week, even when I spoke to Saman Rafiq, who practiced there. And I think after that conversation and after additional articles came out, we actually started moving towards that 10 to 14 day period when we started considering a patient for tracheostomy. And more recently, obviously, we also adopted our approach to tracheostomy also changed in terms of techniques we use to perform tracheostomy. So all of those things have evolved over the past year. I think Carla, do you have well, how about you? Have you noticed your practice altered throughout this past year?
Yeah, I mean, I think as you already said in the beginning, a lot of the societies, surgical and interventional pulmonary and other chest societies came out with tracheing late, 21 days waiting, because there was concern about healthcare worker infectivity and loss of your workforce. If you had all your people doing trachs all of a sudden get wiped out with COVID. But what's really interesting, it's evolved, and there's been some there's an elegant study where they did machine learning in COVID patients. It was published from the UK out of Critical Care Explorations this year, looking at that. And I'll tell you, it correlated well what we saw clinically. So over the first surge, what we saw is that the patients who survived beyond day 14 were probably going to be survivors of COVID. We kind of observed that anecdotally. And so one could make an argument that to trach earlier than 10 days, there's a significant number of patients who may never survive, or they were too unstable to even consider trach anyway. And then you have the patients who are probably between day 10 and 15, they've proven they're going to survive, but for whatever reason, they're either not able to, they're failing to extubate, or there's something predictable about their clinical course. Maybe it's a comorbidity that can almost predict a priority, that they're going to be up a long wean from the ventilator. And so what we found too is we now have shifted our timing to probably evaluation around day 10 to 14. And I think it ties to, the viral infectivity and also the technique. We know that PPE, wearing your PPE works. There was a really nice study out of Northwestern that was just published in, I think, the Blue Journal. It was actually Northwestern. They actually took a group, their group, they had over 450 patients with COVID, 280 of them ventilated, where they did bronchoscopy, just as an example of an AGP. And they were able, it's retrospective, granted, but they were able to kind of do an analysis to determine that there were very, very few healthcare providers, i.e. physicians, performing bronchoscopy that actually became infected with COVID, where it could be tracked to that given procedure. So I think lessons learned are that wearing your PPE properly, having the most expert people doing the bedside procedure, minimizing ancillary staff from being in that room with you if you can, as long as you can perform the procedure safely, and using apnea, especially during trach apnea, making sure the patient can tolerate an apneic period for about a minute, so you can interrupt circuit, clamp tubes, and remove or reduce the aerosolization. So I think we landed with all those things combined that we probably should clearly do trach. I think the take home is do trach sooner than 21 days. If the patient looks to have been viable and improving in all other clinical respects, and we're looking at day 10, 14, that's probably the sweet spot now to consider safely doing trach with those precautions in mind.
Yeah, interesting. I think, here at Davis, we pretty similar to what you did. We moved around. I'm curious if you guys, just to keep the discussion going, we've always done mostly bedside percutaneous tracheostomies, but on a few of our patients where they were outside the scope for anatomy reasons or prior trachs or other things, we obviously involve ENT. And in those cases, every time ENT did it at the bedside rather than taking them to the OR. And I'm curious, I assume the same process is happening, but they were exceedingly worried about going to the OR. The second question is, did you ever use cycle time based on test positivity with the PCR to help decide an optimal time for doing the procedure? And that was for everyone, by the way.
Okay. So I'll take a stab at it. So we've been keeping track of our data, and I can tell that in our institution, about 96 to 98% of the percutaneous tracheostomy in COVID-19 patients were performed by interventional pulmonology group. And out of the past year, about 4 patients were taken care of by our ENT group. And all of those 4 patients, all of them are done by at the bedside. So in terms of our approach to select the timing of the tracheostomy, as mentioned earlier, we have shortened the timing. And anecdotally speaking, we were looking at our patient survival based on our tracheostomy in our tracheostomy cohort. Suffice to say, the patients who are selected earlier on had a over 90% survival rate because of our selection process. Whereas now, as we're getting a little bit more aggressive, or rather more normal range of tracheostomy timing, our survival rate actually dropped down to around 80%. So it's maybe it speaks for potentially delaying tracheostomies and select patients very, very carefully. But that was just anecdotally speaking when we looked at when we're selecting the patient. The really cutoff mark is what Carla mentioned earlier. Can that patient tolerate 1 to 2 minutes of apnea? If they can, then we'll consider them.
Anyplace else doing something different?
I'd like to chime in. This is my first time at these meetings. My name is Julian Lichter. I work at Scripps Mercy Hospital, so I'm a close colleague of Denny. And I would say that just to show that there is some difference in the way that we practice, we as a group had been doing percutaneous tracheostomies on all our patients, but when the pandemic began, we actually had all our tracheostomies done by, it was actually done by our trauma team, because we had a person on the trauma team who had gone to New York, had gotten the COVID, and felt that he was immune, and he was excellent, and he's been doing all our tracheostomies in the OR, and it's been working out very, very well for us. So we've not been doing percutaneous tracheostomies. But I will say this, that many of the patients who are on the ventilator and they're out at day 13, day 14, many of them are still requiring very high FiO2s. They may be on 90, 100%, they may be on PEEPs of 14, 16. And so what I want to know is what kind of level of ventilatory and oxygen support would you say you're requiring before you will allow the patient to undergo tracheostomy, because that may delay our ability to do the tracheostomy?
I mean, I think the selection criteria, I mean, the real litmus test is, I would venture to say a person who's requiring that much PEEP and that much FiO2 would not be able to tolerate an apneic period. And so I think that that's a self-selection, that they're probably not ready for tracheostomy at that level. So, I mean, bottom line for us is if they had hemodynamic instability with escalating vasopressor support, if they were being proned, we weren't too keen on doing trachs on patients who would be being proned, because I think the loss of airway would be a real possibility in those type of cases. And I think patients who are on, a PEEP of greater than 15, or if they're FiO2 of greater than 60%, we had pretty conservative selection criteria just to think of this. I never think of a trach as an emergency. It's not going to save a life. It doesn't really necessarily, there's no clear data, especially in COVID, that it improves outcomes. I mean, there's really no data. There's suggestion and anecdotes, but there's really no clear data that it clearly makes that much of a, the significant difference in their mortality, morbidity. So I think that's a dividing line, I think. I don't know what Colleen has experienced, or George.
Yeah, I mean, I agree with that. I mean, on some of the people who just remain persistently hypoxemic and it gets on and on and on, we have done some of the trachs with the endotracheal tube in place where, you place maybe a P190 bronchoscope through the vocal cord, so you have view of the subglottic space. The endotracheal tube is advanced down to the distal trachea, taking care not to block off a main stem bronchus. And actually with visualization, do the trach, and it's not until the very end during a period of apnea when the trach goes in and the ET tube comes out, kind of as one fell swoop. Those are I think are technically a lot more challenging, because I found a lot of people with COVID have their larynx is quite swollen, and sometimes you just can't get good visualization. But sometimes we've had that opportunity to kind of go that route, so you don't lose the PEEP. You can tell them you can keep them at a high FiO2 with a lot of PEEP for a longer period of time. I don't know if you guys have tried those techniques or what your experiences are with that.
So I tried we tried that technique with a disposable scope and learned not to do it with disposable scope. Is definitely I would definitely say that. So with our percutaneous tracheostomies, we've been relying predominantly on the disposable single-use scope to minimize the amount of equipment that needs to be cleaned and the time that it takes to set up. And so far, we think that at least from the experience that I have is that going with scope in the ET tube, but during that time, tolerating apnea while you're performing the percutaneous tracheostomy it works out pretty well. But if the patient cannot tolerate the apnea, I tend to say that they're not ready.
Well, Christian, one of the other questions, and I'm going to change a little bit. It was the incidental COVID positive patient with the medical illness. What's been your experience up there?
We've had some, what we would call, we usually call them surveillance or asymptomatic testing. And it's not quite right, but that's kind of where we classify them. We've had quite a few patients that meet that criteria, and there's been a lot of inconsistency in how we manage them. It's obviously been a lot more in our surgical patients, but there's been a moderate amount of inconsistency. But we generally are treating those patients as they're symptomatic. They undergo a period of, obviously isolation as they would for aerosol generating procedures. And then we're sort of stuck in this quandary. What the heck are we going to do with them? Because they came in for their heart failure or their tunnel dialysis catheter, and their swab was positive, and now we're stuck with them. And when do we sort of take them off? And what we've been doing is taking the first test day of positivity, waiting 10 days. If they're still asymptomatic, we're using that breakpoint like a minimally symptomatic or marginally symptomatic person based on the CDC guidance. But a lot of this is, just so you know, that's our odd practice here. A lot of it was driven because we had 2 small clusters of nosocomial outbreaks here in one particular wing. I personally, this is my personal bias, I think it's more related to our ventilation. One of them was driven by a mental health worker who was not wearing a mask, which came out after the fact and probably was the nidus. But with multiple patients getting infected, we just sort of went overkill with that regard. So I think we're a little bit more hyperactive, but I'd love to hear what other people are doing. And this was an ongoing problem, and really convincing a lot of our physicians on how to manage these patients and feel comfortable around them has been our ongoing battle up until about 5 minutes ago. So it's been a big challenge. This, and just as an aside, the CDC instruction about wearing 2 masks, this has sucked up a good extent of our day, because we do have quite a few of our physicians who will wear a surgical mask over an N95. But if you read that edict or that statement from the CDC, that's really for the public and for being out. That's not for being in the hospital and wearing PPE. But I spent the better part of the last 2 days telling people that that's not for us, and that perfect fitting N95 you have, or the elastomeric mask or your PAPR, doesn't mean you need an N95, a surgical mask, and then a PAPR on you as you go in. So anyway, I just, sometimes there's battles I won't fight, and I think that's what happened with our asymptomatic medicine people. But sorry for the long description.
Well, I see Rich is done eating now. What's your read on aerosolizing generating procedures that we're doing?
So it's really interesting to look at it. And I think, I don't know, who's in charge? Asha?
Do you
I want
need
to show you.
to share screen?
Yeah, I want to share
Yeah.
the.
I think you
Let me
should.
find
Vicky,
it first.
can you? Yeah.
Let me find the right thing to share before I share the
Please.
text messages my kids send me. That probably would be very helpful. And I think this really tells a good story, because, Asha and I were talking as there were, during the H1N1, there was a bunch of this kind of stuff going on. But in the last couple months even, there have been quite a number of studies that have been looking at this, with systems that can measure, use a laser detector to look at the aerosol in the room and around the patient. And I think this is very helpful right here. And this is, again, all the references are on one side where all this data comes from. But basically, this is the kind of therapy that you're doing, and then the maximum exhaled air dispersion from the patient. So a regular nasal cannula at 6 liters a minute, 22 centimeters. And then here's the high flow nasal cannula piece. And you say, well, the flow's higher. Why is that not even greater? And it's mostly because the cannula is larger and there's a tighter fit in the nares. So compared to, think about the small nasal cannulas that we use, they're usually probably 25% of the internal diameter of the nares. And again, now, if you see it not properly fitted, so, I mean, I'm clearly not working as hard as you guys in the hospital all the time, but you can tell what I do all the time. I have high flow nasal cannulas under my desk at home. But, if you have it like this, where one is blowing out or it's down here, then it'll blow the moisture all around, and there's probably very little you can do about it. In an oral nasal mask that's vented for NIV, a helmet with a tight air cushion, the cushions on the shoulders, and then bag valve mask with a filter. I think the answer is, and what I'm taking from all this, is that it's not high flow nasal cannula or it's not NIV that really is that issue. It's the ability of the patient to cough. So if you have a patient on high flow nasal cannula, or you have a patient on NIV, and they can remove the mask and cough or sneeze, that produces far more aerosol traveling much further than the therapies themselves. But I want to, and I keep telling, of course, the manufacturers want to say, see, high flow nasal cannula is no problem at all. It's not an issue. if you're in the room with a patient on high flow nasal cannula and you're the therapist or the nurse or the physician or whoever, and you've got to be in the room for a long time, you know, put one of the filtered masks on the patient while you're in there, and of course wear your own PPE. But I think the data keeps coming out over and over again that it's, you know, it's not one of those therapies. Now, I'll tell you, I would avoid non-invasive ventilation just because it seems to me like the data is it doesn't work very well in COVID-19. And think more about high flow nasal cannula, and if that fails, intubate. And then I was actually on a call with Michael Klompus earlier today and had a little bit of discussion about this with him, but he wrote this in JAMA Surgery about what's an aerosol generating procedure, because we've talked so much about intubation. And you know, he lists these 4 factors that explain transmission during medical procedures. And I'm not asking you, I'm not telling you you shouldn't be careful. If anything, I'm telling you, we should all be extra careful in the room with the patients. But there's not good evidence that we should avoid high flow nasal cannula or NIV because of aerosolized generating procedures. So that's just my take on it at this point. I'd be glad to hear anybody else. And you know, the AARC has been working on a similar kind of a statement to talk about this, and I think it's pretty much going to say the same thing. If the patient coughs and they're on high flow nasal cannula, it might help spread the cough, but the cannula in and of itself, or the non-invasive ventilation in and of itself, doesn't seem to increase the risk of aerosolized generating procedures. And again, it goes back to the, you know, Michael says, when you intubate, it's not so much that intubation is a aerosolized generating procedure. It might be, it's just that, as you all know, your face and the proximity to the source of the infection is so close that that distance is what really puts you at risk. So again, I wouldn't avoid high flow nasal cannula. I know they did that in Boston back in the spring. I don't think we should avoid it. It seems to work and be helpful in some patients and help prevent intubation. You know, I don't think NIV is good for non-COVID hypoxemic respiratory failure. I doubt that it's very good. If you guys have a different experience, tell me. And again, just continue to wear PPE like you usually do. I know, you know, you got Danny, didn't you? I was under the impression you had gotten COVID and had been sick. So if I'm wrong about that, so
No,
I don't know
you're
how you guys feel about, you know, all this.
So how about aerosolized nebulized medications? Because you know, we were stopped from doing it and had to convert to MDIs, but you know, there's some asthmatics who really, you know, need the aerosol nebulized medications, and we're kind of going back to trying to find out a way of being able to do that safely. I would have thought that it should be no worse than high flow oxygen.
Well, I think you're creating an aerosol, the patient inhales the aerosol, and some of the aerosol particles will come back out. And you know, the difference between humidity, you know, humidity is water in molecular form. So it doesn't carry virus, it doesn't carry bacteria. Now, the condensation can be a vehicle during a cough or spillage or something else. But I think, again, what I've read and what I've seen is that patients who have to have an updraft nebulizer instead of an MDI, it's just a matter of putting the appropriate filter, you know, on the expiratory limb of where the patient's exhaling. I don't know if some of you noticed, Asha and I talked about this. I think one of the papers in Chest came out, and the group from New York actually, and maybe they didn't just finish the sentence, but early on when this was such a concern, they turned off all the heated humidifiers on their ventilators because they were worried that condensation in the circuit would cause a problem. Well, of course, then they had massive numbers of plugged endotracheal tubes from this bloody thick secretions these patients have, and they all had to have, you know, extubations, emergent intubations, or emergency bronchoscopy. So that didn't help at all anybody. It probably increased the risk to the caregivers and certainly didn't help the patients. Again, I guess it's easy for me to say but it seems to me like it makes sense if you can put a good filter, you know, a HEPA filter on the outlet of the humidifier. And just like when we used to deliver pentamidine and ribavirin and some of those other drugs that we were trying to reduce exposure to the respiratory therapists in particular, If you put a good HEPA filter on the external limb, that reduces the risk of it increasing exposure to the patient, to the caregivers.
Carla, you mentioned bronchoscopy and Boston in almost the same sentence, I think. What do you do out there in terms of keeping yourself safe? Do you have a special technique or a procedure that you follow for bronchoscopies in the COVID positive patients?
Yeah, I mean, I think the first thing we ask ourselves is what's the bronch for, and determine, and we kind of stratify, something that's certainly something that's emergent or urgent, we're going to move forward. I mean, example, there was a patient with COVID who was maybe it was about 10 days in, who was intubated. He had, I guess, in the course of this emergent intubation, there was an aspiration of a dental bridge into his right mainstem. And it was a big bridge, and it was definitely in his right mainstem. And so there was no question that needed to be addressed. And so I think that I back up and ask first, is it emergent? Is it urgent? Is it something that can wait? And then are they inpatient or the outpatient? That kind of, and break it down and stratify these patients. And then I think the key comes back is that we know that now more than ever, we know PPE really works. So if wear your PPE, your shield, the hair bonnet, the N95, good seal on it, and then try to work with your team so that you're minimizing, coughing, paralyzing the patients. There's not a cough going on. So even when you're interrupting circuit, you don't have a lot of things kind of pushing out of the ET tube. But I think, that works really well. And I think that, so far, we don't routinely test our providers, but no one has presented who's in the trach team or the bronch team. None of us have had symptomatic COVID. I can at least speak to that. So I think, but having discretion, and then for the outpatient, certainly if they have no symptoms and no contacts, we still have a protocol that they all require COVID testing within 48 to 72 hours prior to coming in for their bronch, because we don't want to delay lung cancer diagnoses. Those are type of things. We've actually, and even though we published this back in March, when the first beginning of COVID, the ABIP on the website, the stratification of bronchoscopy urgency still kind of holds true. I'm sure Colleen probably can comment, and George can comment on their experience too.
Yeah, exactly. I think you're right. We start with is it indicated? And then obviously it's a very, I haven't had an outpatient COVID bronch, and I talked to our procedure unit, we haven't had any. So, and even for inpatient kind of procedure unit bronchs, it's been maybe just a handful. We've done some in the OR, and everything else has been in the ICU. We have I think a very good setup in the ICU. Obviously, staff is super aware of exactly how things should go, which makes it safer. People know how to get in and out and to manage the situation. And then on top of that, like I said, we have some very sick patients, someone who will clot off, one lung, related to being on ECMO and having COVID. And, I certainly feel a lot more comfortable this many months later, with PPE, and that I'm not going to convert than I did at the very beginning. And I feel like, we go in, we do the procedure, and it's, we've also had few conversions.
Yeah, so we follow a similar protocol here. Patients who are undergoing bronchoscopy are usually tested within 72 to 96 hours. If they're positive, then we typically delay their bronchoscopy for at least 2 to 3 weeks, assuming there's no interference to their threat to their life or delay of diagnosis would negatively impact their care. And then so far, with our protocol in place, we have zero documentation of infection from bronchoscopies, and our bronchoscopy has been we have continued actually throughout this entire period, where we have never really shut down the bronch suite during this peak. So I think our comfort level also improved when the vaccine came out. And when when all of us got vaccinated, and it certainly brought us a sense of comfort or a sense of safety to all the support staff. who are in the bronchoscopy room with you.
That it's interesting. That's all. We follow exactly the same with bronchoscopy. I think where we, as a health system, where we ran into trouble was with the definition of a cough. And I will tell you, everybody and their mother and my pet cat comes up with a reason for a cough. So, you're getting your EGD, you get a cough. The thoracic and abdominal surgeon in the OR, anesthesia might not have them fully sedated. And I basically saw them a little bit desynchronous with the vent and they coughed. I mean, literally everybody used every excuse. So that was our greatest challenge, that even, if someone had their, COVID PCR negative the day prior to their EGD and they came in and their sedation was pretty good, they still wanted full gear. And that's been, again, going back to your question earlier, Denny, with our medical patients, that's been our greatest problem. It's really been a difficult challenge. And, Rich, you came up with that's a beautiful table and a nice explanation. And we had used exactly that same document and that same publication with only moderate success at our institution. It's tough to fight.
Oh, you're fighting the fight about taking people when to call them negative though too, right? That's been your bugaboo now.
That's been my battle more recently, but the burn rate for our PPE was just phenomenal. And, it certainly would change our access to healthcare, because you can imagine how you change a room when you consider it an aerosol generating procedure. The time for the next patient, cleaning the room, the turnover is phenomenally long for these patients, even when they've tested negative and even when it's not well documented. I mean, I had at least half a dozen meetings with our GI docs around colonoscopy, based on the initial recommendations back in March with their group suggesting, wearing full PPE and N95s for colonoscopies. And it's been a tough battle. And I'm not even the main ID guy. I just get to play bad cop.
It's still weird to me to look and see Asha and Carla in the same frame. I was their program director and they were co-fellows together. So it's still weirded me out to see you after all these years. So it's good to see you guys. So Carla, anything else on the East Coast that you'd like to share with us on the West Coast to see? Have you figured out the key to this whole mess? Have you?
I wish. I mean, I think that. Thank goodness there's some reasonable therapies out there. I mean, it's kind of interesting to think back where we were and what we were thinking, how we were feeling about all this stuff a year ago, and how far we've come when you really look at it. But I think it's still a work in progress. I think that's why I think this is phenomenal forum that you guys have created, because I think practical real world, and actually bringing to the forefront articles that come out. And, it's challenging to interpret the data because a lot of things now are single center. We're all looking for, something randomized and controlled, but I just think a lot of the things that we've talked about tonight really show the evolution of how we think about AGPs. I think we feel a bit safer. I think that while we still remain careful, we don't have to withhold things that we feel are necessary. And I think evolving the timing of the prognosis of these patients is certainly looking better. I'd be curious though to hear from this group, because I heard a lot of ECMO mentioned, and this is maybe off a little topic, but I'm just curious, how many of your patients are requiring ECMO, and do you have a sense of survival rate in the COVID patient who requires ECMO? Just curious.
Nobody wants to take that one. That's sharing secrets.
I can share ours, and there's no secrets here, which is good. Cone of silence, even though it's being recorded. Actually, if you guys can send this back to my CMO or my chair and get me fired, I would greatly appreciate it. I've been working way too long, so feel free to do so. We actually just reviewed this data. We had a wet lab earlier this week and went over all of our cases, and our criteria has changed, and I think we went over this, that and things are a little different in Europe, but initially we were taking people pretty much based on our prior considerations, which really the general consensus is you don't treat COVID any differently. But if you look in the ELSO database, there were a couple of variations we knew. One is that if your BMI was around 36 and under, your outcomes were quite a bit better. Number two, if you had 4 days of or less of mechanical ventilation, and that included, positive pressure, or I should say invasive and non-invasive mechanical ventilation. So that seemed to be the sweet spot. We extended it out to about 7 days, while we'll consider up to 10 or 14 days for non-COVID related processes. So we changed it a little bit. Most of our consultations we get are patients who are not candidates, either by BMI or length of time on mechanical ventilation. That's where most of our rejections are. Early on, we actually had the first 5 or 6. Out of those, we only had 1 survivor. We had a couple just rough cases, 2 30-year-olds who had hemorrhages and bleeds, and their anti-10As were running around 0.3 to 0.5. We did everything right, and I'm not really sure exactly what happened there. But the last 10 or so came off pretty successfully, even with some right heart failure and difficulty. So our mortality is around our survivability to hospital discharge right now is around 50%, although we still have, as I mentioned, about 6 or 7 in hospital. If they all make it home without an issue, we'll be higher than that. So that's about where we are, which is kind of a little bit below what the ELSO European data is reporting. They're a little bit older average age, a little bit better survivability, but not by much, within the ballpark.
What's your age cutoff, and has that changed?
We went down a little bit. We're using roughly 60, but it's not a hard 60. So we the oldest we've put on was around 64. The youngest was 18. But we're roughly saying 60, but it's not. The only thing we use as a hard rule is a BMI of 40 or more.
Julian, I see you on still on, and you mentioned a while ago some follow-up after people have survived and made it into the LTACs and the skilled nursing facilities, and you really surprised me with some of your information. Do you have any more of that about where they end up and what happens to them?
I don't have anything additional than what I told you earlier, and that was the experience that we had after the first surge. The March, April, May, June surge, and there we were taking in patients to the LTECs with tracheostomies, and we were getting 70% of them off the ventilator and 50% of them decannulated at the time. So, I mean, there is hope way beyond the tracheostomy for these patients. And even more recently, I've had 2 of my own office patients that have been hospitalized on the ventilator, trached, and both of them are at home now, cognitively intact and very weak. It takes a long time for them to recover their muscle strength, but they're going to make it. I mean, I'd like to see how they are a year down the road, but.
I thought that was a fantastic, we need some heartening kind of information like that. We work hard, we get them through, they leave us with their peg and trach, and to hear that you have that kind of success in the LTACs, getting them not out and decannulated and back into an environment with a lot of rehab. I can attest to that. I personally, with myself and my wife, yes, we're still getting some rehab, but it's just heartening to hear that makes me feel better about all the work we're doing up front, to be honest with you.
Yeah, well, we've got to look at the numbers again now after the recent surge. May not be as good, but we're hoping that we're still providing a worthwhile service. I think there was a time when I thought that there was not a place for LTACs in our health system, and they've now become a kind of an important part of the recovery of our COVID patients.
That's great news to hear. One thing I would add is that I don't know about you all, but with COVID, we've had unprecedented numbers of tracheostomy patients under our roof, where there were no rooms at the end of the LTACs. They were so overflowing with non-COVID and COVID patients, that we had to create like a mini COVID trach floor, like an LTAC within the hospital itself to manage the patients, because they might have been able clinically to go out to LTAC, but there were no LTACs to send them out to. They were full.
Yep.
And so I think what it does tell us, though, it accelerated our trach safety, our multidisciplinary team. We always had team huddles of respiratory therapy, the person who put the trach in, the nursing staff, the hospitalist team who was managing them on the floor when they left the unit, and just making sure people knew how to manage trach troubleshooting, the accidental decannulation, the clogged trach, the bleeding trach, because more than ever, we had triple the number of trachs at any given time under our roof than we'd ever had in years because of this combination. And it really lent itself to make sure you didn't have a trach catastrophe when patients were otherwise going to survive their COVID, making sure that if they had something happen with the mucus plugs of COVID, that was a real thing, the mucus plugging, and having acute events. We learned from that. And also it helped us try to fast track patients to downsize the decannulation, so they were not languishing with their 8.0 cuff trach after they were no longer vent dependent. And it really put eyes on these patients where they're not just floating around intimidated, where providers were intimidated by the trach when no one touched it. And so I think that's another thing that was lessons learned for our group, to make sure we really educated all the provider levels, and good teamwork effort. I think good teamwork. And
Anecdotally speaking, percutaneous tracheostomy on patients who are ECMO'd are much easier to do. They hold their apnea longer.
Well, we're almost at an hour.
Right. I was going to pass it over to Asha.
Oh, perfect. I read your mind. So I'm just going to share screen. Thank you all for this terrific
Great.
meeting. And I thank Dr. Chanik, Dr. Chang, Rich Branson, Dr. Lamb for a phenomenal discussion. I think I still have a lot more questions. I'm just an outpatient pulmonologist, and these aerosol generating procedures are going to start entering our outpatient world. I've got vaccines, and a lot of our patients who are vaccinated think they can have dinner parties, and now they're all, I just got off the call. Friends told me we're positive. And so I think the variants are circulating, and we're still going to be seeing a little bit more. May not end up in the ICU, but I think now our outpatient world is going to get inundated with many of the same things that the inpatients have been dealing with, and we still need a lot more information on how to deal with it, because they are going to come to our offices coughing, but they think they're protected having had their 2 shots. And so that's going to lead to our next week's conversation. Vaccines, the monoclonals and variants. And then we're going to conclude, since hopefully this downward trend we're assuming will still hold, into a debrief. I know both Denny and Christian have personal stories with COVID, and I think it's going to be time to have a little wine with some whining, or we don't need a ventilator, we just need to vent. I think that we all need to share some lessons learned, some gripes, just like Christian said, fire me. I would love a stay-at-home order, I think we all feel this, and I think it's time we need to share. And so I thank you all for your attention. Thank our supporters and CTS and all the members that make this state wonderful. And thank you all for your time. Thanks. So anything else, Christian, Denny, our panel?
No, stay safe, everyone. And thanks for all the input. It's always good. I leave here, most of my days, I feel like a complete idiot. So after talking to people, I leave here still as an idiot, but like slightly less self-abusive of the mistakes I make every day. So thank you.
We're in good company. That's all I could say.
It's been hard.
See you guys.
You guys are all awesome. Bye. Thank you.
Thanks, everyone.
Good night. Have a good weekend.